Again, thank you.
And now for those who not left, there is no free lunch. We come now to the Siemens part of the presentation. It's about exploring new frontiers in MRI. I want to talk about motion, and especially also on how to address motion. I mean, this is something which really affects everybody of us, no matter if you work on a 1.5 T system, a 3T system, or a 7T system. Motion is really a crucial thing to address. Otherwise, we need to do rescans or we have problems to analyze our data. So there are a lot of things we need to think about. So luckily, I got some slides from our collaboration partner here, Kineticor. And this is about the quad camera system from Kineticor, which is integrated in our systems. You see it here. There's an arch with 4 cameras. The great thing is that it's really very accurate, 100 micron translation and 0.1 degree rotation with a very high frame rate of 60 frames per second. So this system is integrated actually in our system, the Magnetum Vida and the Magnetum Solar, and it's FDA 510K cleared, which I believe is really a great thing. But the camera system alone is not doing the job. We need something more, and that's prospective motion correction. Now let's just have a look. If you have a volunteer in your scanner or a patient and the person is moving, then the MR reference frame is fixed, but the patient is moving with regard to the MR reference frame. This affects then your acquisition. You have motion artifacts, this kind of blurring and ringing. So what we can do, the camera system is detecting the motion, then correction gradients are calculated and played out immediately to actually adjust now the MR reference frame to the patient. So for the acquisition, it looks like the patient is not moving at all because the MR reference frame is then adjusted. And this gives you, of course, a much better image quality and a much higher diagnostic quality of the data. So here is some clinical example. On the left-hand side, a patient, the acquisition, 2 minutes, 26 seconds, not too long, but obviously for this patient, too long to hold still. It's severely affected by motion artifacts. With prospective motion correction on the right-hand side, this image is absolutely clean. Not absolutely. There are slight artifacts, but it's absolutely of diagnostic quality. Another example here, dark fluid TSE, the image on the left-hand side is of non-diagnostic quality. With prospective motion correction, this is absolutely diagnostic quality. So it's pretty clear that this kind of method can reduce the need for rescans. And for your research, of course, it is important if you go to high resolution. And that's, of course, my personal favorite because this was acquired on a 7T system from our collaboration partner in Magdeburg. It's on a former 7T system with the Kineticor system. On the left-hand side, you see the image without prospective motion correction. Acquisition, pretty long, 23 minutes. So this is even tough for a healthy volunteer to hold still. The image itself looks not so bad. You see the optic radiation, for example, nicely here. You see many details like these very small vessels, but the overall image quality is affected by motion artifacts. With prospective motion correction, the same acquisition then is absolutely crystal clear. And the thing is, you buy a 7 Tesla because you want to increase resolution, but if you increase resolution, you get more sensitive to motion. So this kind of system is definitely important when you really go to super high resolution acquisitions. Now I would like to talk about the second exciting thing, that's MR fingerprinting. We introduced this at this year's ISMRM, that it will be part of our product, and we name it a giant leap for precision medicine. And I would like to explain to you why we really believe that this is indeed a giant leap. But first, it's great to tell you that this was a result of a very fruitful collaboration with the Case Western Reserve University and Siemens Healthineers. And it started, or let's say it became a kind of hype, if you will, with the publication of Denmark's paper in Nature in 2013. And since then, really many people followed up on this, and there's kind of hype in the ISMRM community as well as other MR conferences. And I picked out the second sentence, actually, of the summary of the paper, which I believe is really interesting. The basic structure of a magnetic resonance experiment has remained largely unchanged for almost 50 years. And if you think about this, this is somehow interesting. So how we walk towards a kind of diagnosis. So we image a patient. We see something which shouldn't be there. In this kind, it is a large region of hyperintense signal. Hyperintense is a relative thing. It does not tell you anything about what it is first, but a radiologist, of course, is trained to see what it is. So first question we ask is it a disease? How severe is the disease? A radiologist immediately would see this is a glioma. However, from the image itself, they cannot draw the conclusion about the grading, about the infiltration of tissue further away of the tumor. And of course, there is no way to say anything about the prognosis, only based on those images. So very often, a biopsy is still then done to get information about those questions. In MR fingerprinting, the situation is slightly different. So we do not collect images. In MR fingerprinting, it's all about collecting information. And this information is acquired in a pretty funny way. So we acquire the actual data while we vary all kinds of imaging parameters like the echo time, the repetition time, the flip angle, and many other things during the acquisition. So we acquire actually quantitative multi-parameter data simultaneously. Nobody can actually do something with those data just by having a look at it. It looks really crazy because we have a kind of match of all kinds of contrast behavior in this data set. But what is done then, on a voxel by voxel based, we would look on the specific pattern of the signal variations. So, and this is why it's called fingerprinting. Like if we have the fingerprint of a person and we can send the fingerprint to an archive, then we can collect more information about this person. So if you have a criminal statistic, for example, you may find that somebody is already has become a criminal, you have his name and everything. So the idea of MR fingerprinting is to get this specific signal behavior, and then we match this to a very large MR fingerprinting dictionary. And this allows us then to extract the data to acquire a quantitative map. And important questions are, of course, what can MR fingerprinting contribute to tissue characterization, and what are the relevant regions for a targeted biopsy? And this was studied in a study which was derived by our collaboration partner in Vienna, where they can have scanned, I think it was up to 47 patients with tumor to figure out different information about the malignancy. So a malignant benign, is it a glioma or metastases? Is the region of infiltration larger than this 1 centimeter border around the tumor? And all these kind of very important information. At the end, it's all about trusting the data. So if the data is not robust and reliable, of course, then it wouldn't work. So we need very reliant, robust data. It needs to be reproducible across several scanners or different scanners, and of course, in vivo. And this was now shown on phantom experiments that it's highly reproducible. It was shown across multiple sites, and it was also shown in vivo at the this clinical study I showed you before. And currently, there are 2 manuscripts accepted for publication in radiology. So I think it's really fair to say that this is a kind of next chapter in MRI, and we can even think about maybe in the future we do not look on images, we just look on the case-based data from the MR fingerprinting, and we get a kind of information for the radiologist, which might be then just a number and a region, to identify regions which are suspicious or which are really a tumor. And now I come to my favorite topic, and that's ultra-high field MRI, and I would like to talk a little bit about the Magnetom Terra, which is the first clinical 7T system. It is FDA approved as well as has a CE authorization to market. So we are really proud that the Magnetom Terra is a success story. So currently we have installed 18 Magnetom Terra systems worldwide, and there are plenty of them are coming up. The interesting thing is we see a kind of shift in our new collaboration partners. I always say a little bit sloppy, in the old world it was very easy. I, as a physicist, was talking to another physicist. So a nerd was talking to a nerd. There was a common understanding, a common language. Now we have clinical partners. And a physicist and a clinician have a different language. So it was for us a very steep learning curve to understand what is their need, what do they need, and what do they expect, or a simple question, what is a good image? It was a hard and steep learning curve, but now I'm happy really to see that our clinical partners like the Brigham and Women, Mayo, the University Hospital in Erlangen, or the University of Southern California is really taking off and are measuring patient on a daily basis. Just one very impressive number I heard from Srini Mukundan, who is at Brigham and Women's. They scanned last month 120 patients. And this is really amazing if you think back that clinical studies were not done. It was a little bit clinical research. And a very active clinical site may have acquired this number of patients in 2, 3, 4 years. And they are doing this in 1 month. This was really impressive, and it makes me very happy because I see now we really enter this field. And of course, you can ask the question, why and what is the potential of magnetron terror? And here in this comparison, 73T, and this is about epilepsy. It's a kind of, let's say, low-hanging fruit for 7 Tesla because we have a higher SNR, we have a better contrast-to-noise ratio, and this, of course, allows us to get a better delineation of the lesion itself. So in this example, at 3T, you can see this second cortex here, but it's not very fully seen everywhere, while at the 7T, it's clearly visible over the whole region here. So that's an important information for surgical planning. But even more striking are those examples here. At 3T, this region was not seen as a potential epileptic foci as well as that region on a different patient. While at 7T, it came immediately clear this is a lesion. There's a connection between the cortices. And also here is a lesion. There are connections between the cortices. And indeed, after validation and a surgery, those patients are symptom-free. And this is really the important thing in epilepsy. Every lesion counts. If you miss a lesion, then the surgery is not 100% a success. The person may still suffer from seizure. So epilepsy is where most of the clinical partners are really looking forward and trying to get the benefit out of it, or they are already doing it. Another disease where 7T can help for an early and or a differentiated diagnosis is multiple sclerosis. As you may know, this is a very tricky disease. It appears in very various appearances, and it's difficult to diagnose. However, there are some signs which give you a clear indication that it's MS. So in this case here, what you see, this was actually an MS patient who came in for a follow-up examination. And the radiologist immediately saw this very new lesion in the T2-weighted TSE image on the Terra. And the interesting thing is there's a central vein surrounded by the infected tissue. And if you look on the SWI image, you see a bright ring around the central vein. And this is an interesting thing because there are already some publications out where it's clearly investigated that if you have a central vein sign surrounded by a dark ring, this is a progressing lesion. And this is obviously a very early lesion, so it might be a progressing lesion, has not enough time to accumulate enough iron that it would become dark in this case, so it's still bright here. So this, for example, in the Cleveland Clinic, which is the next sample, they have done some nice studies about this, and the interesting thing, and they compare 3T versus 7T. At 3T, many people rely on T2 TSE or dark fluid TSE. However, in most of those things, MS is not really clear. So on the right-hand side, you see the 3T. The lesions are there, but they are not really clear, is it an MS lesion or not? So in general, you would follow up with an investigation of the cerebrospinal fluid, which is a pretty painful procedure. On the 7T, on the other hand side, you immediately see the central vein sign nearly everywhere. So you can't be really sure that it's MS. And currently, what they are doing at the 7T, they skip T2 and dark fluid. They only go for gradient echo, so SWI, when it's about MS, or MP2-RAGE or MP-RAGE. It's a 3D T1-weighted acquisition when they go for epilepsy. So it's also a kind of paradigm shift for the radiologist. What kind of sequence is a must-have, and what kind of sequence is maybe not a must-have at 7 Tesla. Now, clinical potential. Time of flight angiography, what you see here, is one of my favorite applications because it benefits from 2 independent sources. We have a larger MR signal because of the increased field strength, but we also have a better suppression of static tissue because the T1 is also increasing at 7 Tesla. So this is, of course, interesting to study small vessel diseases, and it could be a potential marker for the integrity, actually, of the atrial phase part of the brain. And it's very obvious that 3T versus 7T, that 7T here outperforms 3T, and most people agree that this kind of resolution is only possible with contrast agent at 3T, not without. So again, this is time of flight, so no contrast agent. And just to show really impressive stuff on top, this is not clinical mode. This is a so-named research mode of the Magnetron Terra. It's a work-in-progress package, compressed sensing, time of flight, so we can accelerate really highly the acquisition. And this allows us to acquire this very high-resolution data set. It's 0.15 millimeter isotropic resolution in less than 12 minutes. Okay, only 1 second less, but 12 minutes, let's say. And if you imagine, if you would put on top now this camera system from Kinetico and prospective motion correction, then this simply means 0.15 is not the limit. So we can even think about going further. And another thing, another highlight I would like to show you is that we have now MNO, we name it MNO, multinuclear option. And here is the sodium imaging that we have clinical approved this functionality. So it's the first time ever that a vendor has done this. Sodium imaging is now clinical approved and FDA released and can be used then also in the clinic. And we are really confident that this opens a window, or a new window actually, in physiology at 7 Tesla. And especially for this community here, which is more neuro research related, it's of course always interesting to study the white matter, so the connections, the connectivity of the brain. And for this, of course, you need strong gradients. And we constantly hear the wish for stronger and faster gradients. And we listen to our collaboration partners, and this is why we are now going for a collaboration project with the University in Berkeley and the MGH in Boston to develop a new gradient coil, which should then be able to have 200 millitesla per meter maximum peak amplitude with a slew rate of 700 Tesla per meter per second on each axis simultaneously. And we expect this to give a big boost actually in the neuro research arena. And actually with this, I would like to end, but first I would like to explain what you see. This is a 0.7 millimeter isotropic resolution T1 weighted acquisition of the brain. And now something comes in which you may have not seen so far. It's an SWI acquisition, but it's with inverted contrast. So you see all the tiny little veins. You also see the thalamus and the putamen nicely. And now the arterial part comes in. It's a time of flight angiography. And if we wait a little bit, because there are so many nice details to see, and we will zoom in a few seconds. The interesting thing is if you look here between the cortical bones, there's a structure, the diploe, which is a kind of trabecular bone structure in the bones, which became visible because we inverted the SWI contrast. I really love it. It looks like a CT image here in this case, but it's an MR. And I just don't love it because it's so beautiful only and amazing. I also love it because it's my own brain, and I'm super proud that this was shown 2 years ago at ICE-MRM everywhere, and I have to tell everybody about it. And with this now, you are free to ask questions or to stay here and come to the front to ask questions or to watch this beautiful movie. Thank you.